I'm, and while we're sitting here, I'm gonna pass out a piece of paper to each of you. If you have an idea for, as you know, certainly we don't want to distract you from the presentation, but if something comes to you about a topic that you would like to hear for next season's, for these talks, please write it down. Because as Debbie and I were saying, it's great for us to be like, oh, we don't think something, email us, but we all know how that goes. It's kind of hard. So no pressure to come up with a topic, but just in case something comes to mind or there's something you've always, hoped that we would do, I'll get you a piece of paper and you can, jot that down for us and I'll collect it. And anyone who does have any, I'll collect it at the end of the evening, okay? So tonight we have, via pre-recording, we have Laura Conjerti, who is a certified genetic counselor. And this topic is interesting because there's a lot of talk among the breast cancer community about genetic testing. Laura, we had originally hoped to have Laura here in person. Unfortunately, there were just some unexpected circumstances that didn't allow for that. So we're really grateful that she took the time to pre-record this session for us. So we won't be able to do live Q&A with her, but if you do have questions, certainly we'll do our best. We can talk amongst ourselves afterwards. And if you do have questions, maybe we can, I can make a list and see if I can get some answers, because I do have connections over also at the, with the genetic counselors over at Roswell. And so I might even be able to get a question answered for you after the fact, okay? But what's great, what's interesting and kind of important about genetics and genetic counseling and testing is that, so I myself am BRCA1 positive, means I have a gene mutation that put me at extremely high risk for breast and ovarian cancers. And actually most women who are diagnosed with breast cancer do not have any known genetic abnormality that puts them at any statistical higher risk than others. However, testing is becoming more and more common with the breast cancer diagnosis because as we're learning more and more about the genetics and as we're getting more and more targeted therapies, they're actually using the information associated with genetic testing to help determine things like treatment protocols. And I know with we had Dr. Tracy O'Connor here, who's a medical oncologist at Roswell. We had her here recently, and she talked about she was talking about metastatic breast cancer and how genetic information, genetic testing is actually important and becoming more important in the way we approach treatment for women with metastatic cancer, and that's certainly true of women with new diagnoses and early stage cancers too. So hopefully you'll find this presentation interesting, regardless of whether or not you had a known genetic mutation or found out you had one at the time of your diagnosis. But I'm going to go do a brief intro here for Laura, and then we'll get started with the recording. Okay. So Laura received her Bachelor of Science in Biology from SUNY Geneseo and her Master of Science from Boston University. She received her board certification from the American Board of Genetic Counseling in 2013 and is a member of the National Society of Genetic Counselors. Laura has worked in both clinical and non-clinical genetic counseling roles and has lectured locally and nationally on topics of genetic counseling and testing. Laura's previous volunteer efforts include serving on the board of the Familial Cancer Foundation of Western New York. So thanks again to Laura for this pre-recording. I hope you all enjoy it, and we will certainly make time for questions, comments, and discussion afterwards. Okay?
Do you want to just hit the arrow there?
I can do that. Oops. Oh, it should be really, really simple.
There you go, that arrow, right.
It says a network error comes from medium down. Let me try putting speed. Try that. Speed.
Okay. Maybe it's
Below that. Do you want to? I know, and I tapped the button and then. Yeah.
Hi, everyone. My name is Conjerti. And I'm excited to present to you today on cancer genetic counseling and testing. My apologies that I'm unable to be there in person today. As Rob may have shared with you, I'm expecting my first baby any day now, so I'm not able to be there physically, but hopefully you'll learn a lot through this virtual presentation. So just a little outline of what we'll be talking about today. I'll be sharing, some of my background with you as a certified genetic counselor, and we'll talk about what happens at a genetic counseling appointment, who might want to see a genetic counselor. We'll talk a little bit about the genetics of cancer, along with genetic testing benefits and limitations, as well as some considerations. So I will use breast cancer a lot as my example, but we do know that a single gene can predispose to many different cancer types. So I do want to make sure that we're including other cancer types when we're thinking about cancer genetics. So a lot of you may have been exposed to genetics, cancer genetics in a variety of ways. For a lot of Americans, they learned about cancer genes through Angelina Jolie. Obviously a big article that came out spotlighting her BRCA1 mutation. For some of my younger patients that I see, they might not remember this article. It came out back in about 2013, 2012, I believe. More recently, although did not make nearly as big of a splash, Beyonce's father, Matthew Knowles, did reveal that not only does he have breast cancer, but also that he has a BRCA2 gene mutation. He was a more recent celebrity to announce, I think, just within the past few years. And I even pulled an article that some of you may have seen made a decent splash about a year ago about a different gene called CALB2. So you will see these things in the media, again, if you haven't already interacted with a genetic counselor yourself. So I've been talking already a little bit about some genes, but just to make sure we're all on the same page, genes are like these instruction manuals for our body. So they tell our body how to work and function properly. And I think of a gene mutation like a spelling mistake. So here's a good visual for you in terms of how our genes are sort of packed onto our chromosomes. And again, if there's a little difference in the gene, that can damage the way the gene works. Again, sort of like a spelling mistake. And so genetic counseling is really this process of helping people understand and adapt to the medical, psychological, and familial implications of genetic contributions to disease. So this is sort of the fancy definition down here, but when I'm giving maybe my elevator pitch on who I am, what I do, I like to explain it as sort of a mashup between a few different healthcare professionals. So I like to think of it sort of as, part counselor. Counseling is in the name genetic counselor, but also someone who specializes in genetics, someone in healthcare, and also a teacher. So it's really all of those things put together that make up genetic counseling. So we use those skills in a genetic counseling appointment to cover these different topics that we're going to dive into in further detail. And contracting is really where it all starts at a genetic counseling appointment. So talking to a patient about what their understanding is of why they've been referred for genetic counseling. Some patients come to me and might say that they have no idea why they're there. Their doctor just told them to come and they showed up. Other patients come in with a really good understanding and they've seen an article, like I mentioned. I've had patients say, oh, I saw the New York Times CALB2 article and I want to be tested for that gene. Some patients think they're only coming in for a blood draw, and I have to explain to them that, while your consults may include a blood draw at the end, there's a lot we need to talk about before we get to that point. What have they been told so far? So it's helpful for me to know going into the appointment, has someone spoken to their friends, family, doctor to get information. Have they done any of their own research and what they're hoping to accomplish? Because really, at the end of the day, it's about making sure that I give the patient the information they need, but also that they get from the session, you know, what they were hoping to, or I can establish right from the bat, maybe they have a question that I can't help them with, and establishing that up front so there's not disappointment at the end. Really, the next step in a genetic counseling appointment is for me to gather some information about that patient. So perhaps I've got some of their medical history from the notes that they're bringing into the session, but and even maybe some family history. But genetic counselors often take a 3-generation pedigree. So that may be asking someone about their children, their parents, you know, but we really go back as far as we can. So if a patient has knowledge about their great-grandparents, I'll always take that. In fact, first, second, and third degree relatives are really all the people that might sort of count towards insurance companies covering the genetic testing. And so for that reason, relatives like great-grandparents, even great aunts and uncles can be important individuals in the family history. Excuse me, when I'm gathering information, I'm looking for different red flags, and then I sort of do an analysis of what I've seen, and it's at that point where I give some information to the patient. So, you know, telling them a little bit about these cancer genes and the risks associated with them. Again, some people don't have any knowledge coming in. Maybe they've heard of BRCA1 and 2, but they don't really know what that means. Talking about the inheritance risks. So with many of these cancer genes, the chance of passing that gene mutation onto a child is 50%. So going over those types of risk numbers, what's the risk to a sibling, a parent, etc. Talking about the benefits and limitations of testing, and also directing them to any resources. So when I was working in a clinical role, I often gave out brochures to patients just so they would have something to look back at, especially because genetics is a family affair. You know, you're not going to bring your whole family to your genetic counseling appointment, but you want to be able to share some information with them afterwards about what you learned, and even websites, so that you know, you can email it off to whoever you'd like, so that everyone is in the loop. Another aspect of a genetic counseling session that really runs throughout is just the psychosocial component. So, you know, readjusting any expectations that the patient had maybe coming into the appointment or had about genetic testing or genetic counseling. You know, talking about the potential family and marital strain a gene mutation may cause. Again, of course, the impact on other family members, understanding that sometimes, you know, there's still a big impact on individuals in the family who are not impacted by a gene mutation because, you know, they may feel some of what we call survivor's guilt, you know, not having that mutation. Just talking to patients about how they are going to share this diagnosis with their friends and family. After all of that is done, you know, we've talked about testing, often insurance companies, insurance coverage comes up. And so most patients often who do qualify for genetic testing, I should say, so patients who have red flags, often pay $100 or less for their genetic test. And for some individuals, when it's considered to be a preventative service, it's $0. Which is great. And I do like to mention that for individuals who don't have any of the red flags that we're going to talk about coming up, someone who might be low risk to have a gene mutation, those individuals are still welcome to do genetic testing. It's just that insurance may not cover it because the risk that we would find a mutation is so small. But those individuals can still pursue testing as an out-of-pocket expense of $250 is what's currently available. I make sure that the patient would know how they're going to get their genetic test results. Is it going to be over the phone? Is it going to be in person? Some people are really anxious about receiving their results, so just knowing how or when they're going to get the results is helpful. And then talking about next steps, you know, we need to refer the patient to any other healthcare professionals? Should we recommend testing for family members, etc.? So who should go through all of that? Who should see a genetic counselor? So a couple of things that I'm always going to be looking for, and that hopefully your healthcare providers are looking for, whether you're going to see, your medical oncologist or your primary care physician, they should be identifying you to see a genetic counselor. But it's great to be aware of these things on your own, so that if you think you do have a red flag but you haven't been referred, you can schedule an appointment on your own. So it does not require a referral to come see a genetic counselor. And again, it's just this conversation. Just because you see a genetic counselor doesn't mean we're going to do testing. But people who definitely want to consider seeing a genetic counselor is someone who's been diagnosed with cancer at an early age. So this is going to be, generally 45, 50 years or younger. We'll talk a little bit more about the types of cancer in a bit. So I'm not worried about people with skin cancer, let's just say, because we know that most skin cancers are caused by sun exposure. I'm not worried about women who are diagnosed under age 50 with cervical cancer, because we know that most cervical cancer is caused by HPV, or the human papillomavirus. So that's not a cancer that tends to be genetic, but things like breast cancer, ovarian cancer, pancreatic cancer, colon cancer at young ages, endometrial cancer, or uterine cancer at young ages. Those would be the types of cancers I'd be looking for. We're also looking for people who have more than one primary cancer, or bilateral breast cancers. So it could be two different types of cancers, or maybe two breast cancers in the same breast when they're different. Or even one cancer, or two breast cancers, but one in either breast. We're also looking for rare cancers. So ovarian cancer is fairly rare. Male breast cancer is extremely rare. We're also looking for families where there's multiple relatives with the same or related cancers. So that could be someone with, I'll give some examples on the next slide. We know that individuals of Ashkenazi Jewish ancestry are at elevated risk of having a gene mutation. So for those individuals, the threshold to do genetic testing is a little bit lower. And of course, if you know that there's some family history of a hereditary cancer syndrome. So by that, I mean, did your cousin tell you that they tested positive on their genetic test result? That's going to be a reason for you to consider, at least consider genetic counseling and testing. Okay, so some examples. So, maybe you have a sister diagnosed with endometrial cancer at age 45. That would be a red flag to me because of the young age of diagnosis. Maybe you'd consider genetic counseling if your mom had a left breast cancer when she was 47, and then a right breast cancer when she was 61. So two separate breast cancers. Maybe you have a grandmother with ovarian cancer. That's an example of a rare cancer. Maybe you have three relatives all on the same side of the family, like a cousin, aunt, and grandmother, who all have a history of breast cancer. Maybe you yourself are of Ashkenazi Jewish descent and you have a diagnosis of breast cancer at any age. That's going to be a red flag. I should mention a lot of people have learned that they have Ashkenazi Jewish ancestry through some of the at-home DNA testing that's available. And usually we're looking for individuals with, every genetic counselor would probably have a different threshold for this, but, at least, a 10+%, 10% of your ancestry is Ashkenazi Jewish ancestry. There's a lot of people who come back on the at-home DNA test with like 1% or 0.1% Ashkenazi Jewish ancestry, and that's not enough to raise your risk significantly to have one of these mutations. So we're looking for someone with a more significant portion of their ancestry being Ashkenazi Jewish. And again, having a gene mutation in the family, especially a parent, is going to put someone at high risk. That would be another person who should consider genetic counseling and testing. Okay, so when we think about genetic testing, and like I mentioned, any of those individuals could be good candidates. We've gone over the red flags of who might want to consider genetic counseling. But again, just because you do the counseling doesn't mean you're going to do the testing. And so that could be part of the conversation with the genetic counselor. I'd like to use this this example of this red apple tree to sort of illustrate who in the family should do genetic testing first. So starting with the apple tree on the left, you see that there's all red apples on this red apple tree. And then I will usually say to my patients, you know, now you see this tree on the right, all of a sudden this yellow apple has sprouted up on your tree, sort of unusual. If we wanted to answer the question of why did an apple on the tree turn yellow, what apple would you want to pick to do some testing on? And the answer to that is that, excuse me, that you want to pick the yellow apple. The yellow apple is the one that's different. So if we want to figure out why it's different, let's test the yellow apple to just try to get right to the bottom of things. And so the person in a family with cancer is sort of like that yellow apple. We want to start by testing the people in a family with cancer before we go testing people who have not had any cancer. So it really is doing, you know, potentially an entire family a favor when someone with cancer gets tested, because their results can inform other relatives. So again, thinking of this tree on the right, the person with cancer is like the yellow apple. That's the person we want to test. All the red apples are the people who have not had cancer. So that's where we want to start, is testing the person in the family with cancer. Okay, so let's talk a little bit about the genetics of cancer. And usually when I show this slide, it's a bit of a surprise to some people to think that all cancer is genetic. So all cancer is genetic, it's just not all inherited. So the top example, or the top picture, is how most cancer happens. Most people start off with 2 normal copies of each cancer gene. And these cancer genes are actually working to protect you from cancer. Over time, or what you can see after the first arrow, is that sometimes a copy of our gene becomes damaged. That can happen due to aging, lifestyle, environment, or maybe just bad luck. But one gene gets damaged, but we don't have cancer yet because we have that other healthy copy of the gene to protect us. It's after we acquire that second mutation that then cancer can happen, because our body doesn't have this instruction to keep us healthy. So one way you could think about, again, that top example, just sort of a more straightforward example, is that maybe someone is born with 2 normal genes and they smoke. And smoking damages one copy, they smoke some more, the second copy of that gene is damaged, and then they develop lung cancer. So that's how most cancer happens, is that top row. But most lung cancer is not hereditary, but what I'm showing you is that it is genetic. It's caused by these gene mutations. The bottom row is showing how hereditary cancer happens. So when I say that someone has a gene mutation, it means that they are born, or they start with one gene already damaged in every single cell of their body. And all it takes is that second mutation to be acquired to end up with cancer. So again, someone basically starts off at a disadvantage because they're born with a gene mutation, and all they have to do is acquire one mutation. And that could be from, like I said, just could be aging, it could be bad luck. But that's how hereditary cancers happen. Again, it's still genetic, it's still caused by the genes, but these people started off at a disadvantage. And that's why we often see cancers happening at younger ages. You can see the bottom row is literally, there's one less step than the top row. And so that's why some oftentimes hereditary cancer syndromes can lead to cancers at younger ages than just more sporadic cancer types. And this is a great segue to say, well, like, how much cancer is that top row, just sort of random, and how much is hereditary. So what we know, at least when we're thinking about breast cancer, I'll use that as an example, is that about 5 to 10% of all breast cancer is hereditary. So it's a pretty small group of people. And that's why I think, when you put this into perspective, it might help you understand maybe why your insurance company is not covering genetic testing for you, right? So if you're a 70-year-old woman who develops breast cancer, you've got no family history, there's such a small chance that you're going to wind up in that hereditary 5 to 10% because you don't have any of those red flags. The more red flags you have, the more likely it is that you're in that 5 to 10% of breast cancer that is hereditary. We do think that about 15 to 20% of breast cancer is familial, meaning that it's clustering in a family, but there's not necessarily a gene. We know that families share more than just their genes, right? They might be eating the same foods, drinking the same water, breathing the same air. So some of that can contribute to why we are seeing breast cancer cluster in a family. And then again, a good majority, about 70 to 80% of breast cancer is just completely sporadic. When it is hereditary, what you can see is that BRCA1 and 2, they get a lot of press for a good reason. They make up about half of those hereditary breast cancers. But there are a lot of other genes. Like I've mentioned, one of them today is CALB2. You'll see a few others later on. And then there are still some genes that we probably don't know about. And that's why it's really important to stay in contact with your genetic counselor over time. There may be more genetic testing that you could benefit from in the future. And we'll talk about that a little bit later too. Most of these cancer genes are autosomal dominantly inherited genes. So what I mean by that is that, we all have 2 copies of all of these genes. We get one from mom, one from dad. All it takes is one damaged copy coming from one parent, could be mother, could be father. All it takes is that one mutation present to be what we would call affected with the genetic condition. Although just because you have the gene mutation, it doesn't mean that you will get cancer. It just means that you have a higher risk of cancer. So let's talk a little bit more specifically about the genetic test itself. This probably looks like a lot of alphabet soup to most people, but this is actually a list of a good majority of the cancer genes that are out there. And I, use this slide just to illustrate that BRCA1 and 2 are just 2 of the 80+ cancer genes that we know about. So if you've only been tested for those 2 genes, BRCA1 and 2, there's a lot more out there. And this is really where meeting with a genetic counselor, especially a certified genetic counselor who has a lot of background knowledge on these genes and who needs testing for which genes. To make sure you're getting the right genetic test is really important. So like I mentioned, there are a lot of different breast cancer genes. Many of them are listed here. And again, it's going to depend on who you talk to. And the research that's just come out is exactly how many there are, but certainly there are many that are well recognized beyond BRCA1 and 2. And again, just to make sure I've been clear on what these genes do, having a gene mutation in one of these genes increases a person's risk of developing certain cancer types. And each gene predisposes to different types of cancer. So this P10 gene, as an example, predisposes to breast cancer, thyroid cancer, and endometrial cancer. So if someone has that one gene mutation, they have all 3 of those cancer risks. So hopefully that's making a little bit of sense. As for colon cancer, there's, again, more than a dozen genes here that can predispose to colon cancer. One example being the MSH2 gene. that predisposes to not only colon cancer, but endometrial cancer, stomach, and ovarian cancer. So one gene puts one person at risk of all of those cancer types. Now you can still see that the risk of cancer is not 100%. So just because you have an MSH2 mutation doesn't mean that you will get cancer. It just means that you have a higher risk. Prostate cancer genes, there's many of these as well. We usually think about prostate cancer having a higher likelihood to be hereditary when it's aggressive or when it's happening at a young age. So I'll often ask men about the Gleason score. The higher the Gleason score, the more aggressive, the more likely it is to be hereditary. BRCA2, again, a lot of people think of that as a breast cancer gene, but it does predispose to prostate cancer in men. So those would be some things to be aware of. Again, one gene predisposes to multiple cancer types. There's many different genes. And then again, a lot of overlap. So I think of it sort of like a Venn diagram where a gene can touch a lot of different cancer types. And that's why I like to sort of speak broadly when I talk about cancer genetics instead of saying like, this is breast cancer genetics, because breast cancer genetics is also, you know, prostate and ovarian cancer genetics. So covers a lot of things in one. I always like to include just a little bit again, knowing, you know, what you might have been exposed to before this presentation, thinking about something like 23andMe, if that's maybe been your exposure to genetic testing. They do have an ancestry test where you can find out, you know, your ethnic background. But they do have a second test that includes the ancestry component with what they call some of their health testing. Now, the important thing to realize about this testing is that it's just not as comprehensive as what you can get through a genetic counselor or your healthcare provider. So we know that the BRCA1 and 2 genes, they have there are more than 1,000 possible mutations within those 2 genes. But 23andMe, when they do their test, they're only looking for 3 of the most common Jewish mutations. So it's typically accurate if they find a mutation. The problem is because they can only see such a small portion of the mutations in those genes, most people come back with a normal result and they say, great, my BRCA1 and 2 genes look normal. And that's just not the case. Because they didn't look for those other mutations, we wouldn't know if one of those individuals has a mutation in one of those other genes, or excuse me, a different mutation in that gene. And therefore, the testing just wasn't comprehensive. It doesn't cover everything. So just because the result is negative does not mean you're in the clear when you've done this 23andMe testing. Same thing goes for a gene called MUTYH or MUTYH. This is a colon cancer predisposition gene that 23andMe in the past few years has started testing. And they're only looking for 2 mutations out of the possible more than 100 mutations in the gene. So it's just important to know what you're getting yourself into when you're doing this testing. Not to say that when you get a positive, it's not accurate. It's just that it's not comprehensive. Now, a lot of people say, okay, great, I'll do the testing, you know, but what changes if I have a gene mutation, right? Like, what's the purpose of all of this other than to tell my family, perhaps? And there are a lot of important implications. So as one example of what someone might do differently if they have a gene mutation, is they might start their cancer screening at earlier ages. So for example, they might start their colonoscopy at age 40 instead of starting at age 50. Or maybe a woman with a breast cancer gene mutation might start her mammograms at age 30 instead of age 40. So that's a big difference. You know, to start that screening earlier could be really important to catch cancers at younger ages. And when people have these gene mutations, they're more likely to develop cancer at younger ages. In addition to starting screening earlier, someone might add an extra cancer screening. So Many average risk women will not qualify for a breast MRI every year, but if you have a gene mutation, that might be something extra that you qualify for. And so again, just trying to pick up cancers at as early a stage as possible. So those are just a couple of examples of what someone might do differently. And of course, again, being able to discuss it with family members who might also be at risk. But I think it's just important to know that this isn't just being done as research. It's not being done just for curiosity's sake. It's being done because there's something we can do differently that would improve health outcomes. But like I mentioned, with only about 5 to 10% of breast cancer being hereditary, it does mean that we test a lot of people that have normal genetic test results, meaning no gene mutation was identified. And so in that situation, we're still going to continue to base their cancer screening on that person's own history and maybe even their family history. So we can't just always ignore the family history when someone's results are normal. We might still say, listen, we still have to start screening earlier. Like if a mother was diagnosed with breast cancer at 43, even if she has a normal genetic test result, her daughter should still start their breast screening 10 years before their mom was diagnosed or at age 33. And that's because if genetic testing is normal, we don't know why a person developed their cancer. What if it's a gene that we haven't discovered yet? We don't want to miss out on some important screening for that woman's daughters. And if your results are normal, again, this is where a conversation with a certified genetic counselor really comes in handy to make sure that, sometimes family members need testing, sometimes they don't. So that can be fairly nuanced. Again, just like to make sure I've driven home the point that just because you have a cancer gene mutation does not mean that you have cancer. Especially if maybe you had breast cancer in the past and now you're doing cancer genetic testing. Just because we find a gene mutation doesn't mean that you have a new cancer or even that you're going to develop another cancer. It could maybe just tell us why you had that breast cancer or about your risk for subsequent cancers. Like I've mentioned, some people with these gene mutations will never develop cancer in their lifetime. They're just at a more significant risk. Again, I've explained that there are a lot of different genes associated with different cancer types, but it is important to know that we sort of use these 3 different groupings to categorize genes. Some genes like BRCA1 and 2 are high-risk genes. Those are associated with highly elevated risks of cancer. Moderate risk genes that are associated with just a moderately elevated risk of cancer, so not as significant as high risk. And we're going to have different management recommendations for those 2 groups. So just because you have a mutation and your friend has a mutation, it does not mean we're going to treat the 2 of you the same. And then there's newly described genes, or genes that we're really still learning about. So for some patients, they're curious, they want to learn as much as possible, even if I don't have a definitive answer to give them. And other patients, finding out about a newly described gene can be a little bit frustrating because we don't have all of the details worked out just yet. So again, important to have a conversation before you do the test to make sure you know exactly what you're getting yourself into, what types of information you could learn from the testing. Which is pretty much covers the slide in terms of which genes should we test. It's just an individual decision. So a lot of people will look to me for guidance and say, well, how many genes would you have tested? And without usually saying how many I would test, they say, well, if I was feeling anxious about the idea of learning about a newly described gene, I might test a little less. If I just love information and want to know as much as possible, I might test more. And so, that's really what someone can walk you through when you're deciding on your genetic test. Again, we've talked a lot about breast cancer, but ovarian, uterine, pancreatic, kidney cancer, melanoma, so it's the most aggressive form of skin cancer. All of those different cancer types can have an inherited predisposition, but things like cervical cancer, lung cancer, those are not typically something that a person is predisposed to and may not factor into a cancer genetic counseling evaluation. Really, when we're doing genetic testing, you know, every patient needs to weigh these benefits and limitations for themselves. So, you know, the benefits of testing you can see on the right are things like knowing how to appropriately manage someone's cancer risk, being mentally and emotionally prepared. You know, I think it's something to be, there's something to be said about knowing what's ahead for some people and saying, you know, I know there's some breast cancer in my family. What's the chance this is really going to happen to me? If it would help you to mentally prepare by having this information, you know, that could be a real benefit to genetic testing for you. You can advise your family members and maybe even get better insurance coverage of certain types of cancer screenings than you would if you didn't know about a gene mutation. The limitations of testing, again, just some of the limitations for some patients might be that if you do get a normal result, it doesn't necessarily mean you're off the hook per se. You can still have a elevated cancer risk that we need to be aware of. For some patients, this is all just too much information. It might cause them some anxiety, depression, to know they have a mutation, so maybe it's best to just not test at all. And then the risk of genetic discrimination, which we'll talk about. The testing is changing so rapidly though. So anyone who had genetic testing before 2014, I would say a lot changed right around the 2013 mark. So those individuals would certainly benefit from some additional genetic testing. But it really depends on who ordered your genetic testing, how many genes were included. So it never hurts to meet with a genetic counselor again, just to say like, hey, are we missing anything here? Is there anything new I could benefit from? Yeah, we didn't talk a lot about result types, but sometimes when results come out initially, they're called uncertain or a variant of unknown significance. And eventually we figure those things out. We eventually can say that's a positive or a negative result. And so that's something that changes with time. And then even if you have a gene mutation, our recommendations on what to do about it might change. So again, all just important reasons to make sure you and your healthcare providers are staying on top of your genetic result. Some good resources that I like to share is a group called FORCE, or Facing Our Risk of Cancer Empowered. So again, I know that you're watching this presentation as part of the Breast Cancer Network of Western New York, but if you're looking for something that's focused on genetics, FORCE is a great place to start. National group, all different types of cancers covered. Bright pink is more focused on hereditary breast and ovarian cancer, and it's especially designed for young women. So if you have a daughter or a granddaughter, this could be a good resource for them. Usually I think they're targeting like a 40 and under group. Last thing we'll cover are genetic testing considerations. So usually the last step in a genetic counseling appointment is to go over an informed consent document. Once you know your genetic test results, you can't go back. It's permanent. And it is a family affair. So it's important, like I've said, to know what you're getting yourself into. I'm starting to feel like a broken record here, but it really is important. And testing may not be appropriate in most cases until 18 years of age. When I was working in a clinical role, I was very much open to meeting with individuals younger than 18 to have a conversation around testing, but it was extremely rare that we would actually go ahead and test someone who was under the age of 18. So usually having those educated conversations can help that young person understand why it's to their advantage to wait. And in an informed consent document, you also might learn about what your sample is going to be used after testing. So some people worry that their sample could be misused, and all of that would be explained in the informed consent in terms of what would happen. Standard practice is that New York State mandates that samples be destroyed no more than 60 days from when they were taken. So in many instances, your DNA is not floating around for very long. As promised, a little bit about genetic discrimination. GINA, or the Genetic Information Non-Discrimination Act, has been in effect for more than 10 plus years now. And this prohibits discrimination when it comes to employment and health insurance. So you cannot be fired from your job just because your employer finds out you have a gene mutation. Your health insurance cannot raise your rates because they find out you have a gene mutation. So that's what is protected by law. Unfortunately, what's not currently protected by this federal law are things like life insurance, long-term care insurance, and disability insurance. There's a few small caveats to the law, like the fact that it doesn't apply to employers with less than 50 employees, but it does offer some protection. Now, some states do have additional protections that might protect things like life insurance that go beyond GINA, but right now, to my knowledge, there's nothing additional that we have in New York State. I know California has some additional protections in Massachusetts, just off the top of my head. The test itself can be done on either blood or saliva. Either is accurate. So your DNA is the same in all the cells of your body. So no matter which sample type you submit, you're going to get the same result. So if you hate needles, the saliva can be a nice way to go. Other people are very dry mouth. Maybe you're taking medications that have dry mouth as a side effect. So maybe blood turns out to be easier. It's totally patient preference. Lab selection. So that, really depends on the patient's insurance. If your family member has already had genetic testing, we might want to keep your testing at the same lab. And in terms of how long it takes results, on average, about 2 to 3 weeks is pretty typical. Now, if you do want to find a genetic counselor, there's this option to go on the National Society of Genetic Counselors website, and you can type in your zip code to find someone near you if your healthcare provider can't help you identify anyone. But just to wrap up, hopefully you've learned a little bit more today about how genetic counselors can help individuals learn more about genetic testing. We went over the different red flags, things I might be looking for as a genetic counselor in someone's personal or family history that might tell us we need to dive a little further. There could be a genetic cancer syndrome. And then just that these genes are unique. They each have a different impact. So you want to make sure if you're ever looking for information that you're comparing apples to apples and not apples to oranges. And then making sure you've weighed the benefits and limitations of genetic testing before you go ahead and pursue it, because once you know, you can't go back. So there's just a few of my references, and I just want to thank everyone for your time and for listening today. Rob can certainly pass along any questions you might have, but like I said, given the circumstances, it might just take a little bit longer for me to respond than usual. But I hope this has been informative. I'm sorry I couldn't be there in person, and yeah, I just wish you all the best. Have a wonderful summer. Thank you so much. Bye-bye.
So, what did everyone think? Does anyone immediately off the bat have questions or anything you want to offer? I have so much going on in my head, but I'd rather just wait and see if anybody else has anything they'd like to share.
I have a question.
Yeah.
Would they consider, or would you have a genetic testing done more than one time?
That's a good question. I would think that based on what Laura shared, I would think that there could be a reason to do it more than once, but it would probably be, like she said, if it was done quite a while ago and maybe things have really changed since then, or if you maybe had a very narrow focus, like a single gene was tested. So I can give you an example. My family, we know that on my mother's side, we have the BRCA1 gene mutation. My sister, when my younger sister got tested, my mom actually never was tested. But we know that she has the gene mutation because my sister and I have different biological fathers. If we have the gene mutation, which means it had to come from my mother. And my mother had breast cancer at 38. So, the odds were pretty high, especially with all of it. But my sister, when she had her gene testing done. She did the full panel, so they tested everything for her. When I chose to get tested a year later, I only opted to have, when I went and met with a genetic counselor and we talked about some of the considerations, what she was talking about. And that was in 2016. And we talked about like new, like unknown variants or possibly coming up with some things that were like, yeah, this is a mutation, but we don't know what that does. And as someone who used to have a lot of anxiety, I decided that what made the most sense is we knew that the BRCA1 gene mutation ran in my family. We knew that there was about 50% chance that I had it. And my sister had already done other testing and didn't come up with anything else unusual except for that BRCA1. So I chose to only test the BRCA1 gene. Now, could at some point I maybe decide that I wanted a more comprehensive panel? That would probably be the reason to have a second to get tested again.
Yeah, I have been tested twice.
Okay.
I was tested in 2014, I think just for the BRCA 1 and 2, and I was negative. And then just last year when I was diagnosed, I did the full
Panel.
spectrum of genetic testing. Unfortunately, I have a variant of unknown significance. And,
Okay. So
I'm
that's
now H1. so-
okay. Yeah. And as as Laura said, odds are that at some point they're going to know the significance of that gene mutation. It's just that right now that information hasn't been.
So if I
Identified,
didn't go,
yeah.
I would think, oh, well, this can't ever be genetic, but now I know it.
Yeah,
There's a
hereditary.
possibility.
Yeah, absolutely. And just like for a long time, I mean, the BRCA1 gene mutation was becoming, the BRCA1 and 2 were really starting to come to light in like the late 80s, around the time my mom was diagnosed, actually. And now we know that there's all, so it used to be, it's like, well, that was the breast cancer gene mutation. And now we know that there's lots of others, and I know people who have the PALB2 and the CHEK2 and ATM and those, and so again, they're continually finding more and more information as research is done on gene expression. Anybody else?
I was,
Considerations.
didn't catch, I wasn't listening. Probably. Close enough, but what did you say about the thing, your DNA is destroyed?
Well, that's okay. So they have to take DNA. That's how they do, either through blood or saliva. That's how they take the sample for testing. And that was around privacy concerns. So what she said was they destroy, at least in New York State, they destroy the test sample, whether it's the blood or the saliva, they destroy that in no more than, they have 60 days to do that, so that your genetic sample isn't floating around out there for misuse. So that was more of a privacy concern.
I think my concern was that years ago, Roswell, my husband and I both banked our DNA, and it's out in Idaho someplace, moved from one place to another. And I thought, well, now did you destroy it now?
No, this was specifically.
That was different, and that's just if I was to go again for testing.
Yeah, this is specifically
Again,
related to, yes, this is specifically related. I would think anything that you did and had, under that circumstance, it sounds like that was the intent of it, was to hold onto that. So I would imagine
Yeah,
that
so
that
the
is.
children could blame us after we die.
There you go. There you go. Yeah. It's interesting that you say that, because that is when she talks about family considerations, being someone who did grow up with this. My great grandmother died of metastatic breast cancer. My grandmother had it. My mother had it. My grandmother actually had breast and then ovarian. My mother had breast. And it's kind of been talked about in our family that, when my mother was diagnosed, we didn't know. Even when my mom had us, we didn't know about these gene mutations. We didn't know about this high risk, other than, people in the family had it. And I remember my mom telling me that my grandmother cried and said, I did this to you. I'm so sorry. And of course my mom said, no, you didn't. And when I was diagnosed, my mom said, I did this to you. And I said, no, you didn't. Would you have changed your mind? Right? I mean, I hope you would have still had me, because it isn't a guarantee. That said, people do make life choices based around this information. So when I was growing up, I'm 46 now, and when I was young, my mom was diagnosed at 12. So I spent a lot of my life understanding that breast cancer was a part of my life and my family. And I had my first mammogram at 23 and went every few years until 30, and then every year after that. And at the time, this was obviously pre-2008, I remember talking to doctors about gene testing. And back then, it was actually discouraged because of my young age and because of insurance considerations. They were concerned that I would face insurance discrimination. And so I actually never got tested until 2016. I was treated as high risk my entire life. In fact, I've been in Buffalo 8 years, and when I came here in 2014, that's when I started getting both annual mammograms and annual MRIs, as well as transvaginal ultrasounds, because with the BRCA1 mutation, my chances of having breast cancer statistically was up to 87% that I would have breast cancer in my lifetime. In my family, it's pretty much 100%. And that is what happened. I was diagnosed at 41 in 2017, so a year after I got tested. For me, getting tested was just a confirmation of something, the way I had lived my life up until then. I actually remember thinking, I think I would have been more discombobulated if they had told me I didn't have the gene mutation, because that would have taken this lifetime of high risk and put me back into the kind of general pool. And like, you know, that would have been more confusing than just continuing on the path of, okay, this is likely to happen to me. But you know, some of the decisions that people come to, it does affect, you know, I don't have children. I did not choose not to have children because of my high risk of breast cancer. But I can remember being in college with my high school boyfriend, or my college boyfriend, who became my first husband. And I can remember thinking about our future and wondering, you know, what would happen if we got married and have kids. And that's something not a lot of 19-year-olds get really, you know, think about or get really upset about at the time. And now my sister, who's in her mid-30s, is actually in the process of exploring prophylactic mastectomy, because we know in our family, the odds are just too great. And if she can, I was never ready to make that decision, but for some people, that is where it goes, because while screening is really important and certainly can help find things early, it still isn't prevention, right? And the only true prevention or risk reduction that's significant would be to have a prophylactic surgery. For me, I opted to, when I was diagnosed with breast cancer, because I had the also increased risk of ovarian cancer, which was like up to around 67, 65%. And we knew that ran in my family too, that my grandmother had that. I opted for prophylactic, they call a salpingo, bilateral salpingo oophorectomy. So I had my ovaries and fallopian tubes removed. And for me, that was an appropriate choice at the time, because I was old enough to know that I wasn't going to have children. I was still premenopausal, but it was, for me, that was empowering, because it meant that I didn't have to go on worrying for that to catch up to me too. And that has given me, you know, with this kind of information, it's given me a lot of peace of mind that I didn't have before, and also saved me a lot of time and money and worry going every 6 months for blood work and testing. You know, obviously I still go for now for all the breast cancer stuff, but at least that's one other thing, my ovaries, that I don't have to worry about. So there's, you know, for me as someone who has been directly impacted my whole life by this, you know, a gene mutation, this presentation was just mind-blowing, because so much of it spoke to me. I've either been through it or experienced both sides of it. And so I can tell you that, you know, Laura did a phenomenal job with really, you know, being very comprehensive in this. And what I really appreciate, and I do highly recommend, and I'm glad she talked about this, is, you know, science is so cool, and it's really, it's amazing. And it's really cool that we have so much more accessibility to certain things in science, like our ancestry, like, you know, like getting kind of this easy access to some of this. But as she explained, there are a lot of variables and considerations when it comes to this kind of thing. So while, you know, things like mail-in DNA and all of that is awesome for something like Ancestry. If you're talking about your health, genetic counseling really is a key component because, you know, even with all I had stacked against me, when I talked to the counselor, you know, one, it was very much about hope and empowerment, and two, it was really about the counseling. Like, nothing happened with the actual testing until the end of that counseling appointment where I made the decision, yes, I was going to get tested, that was the right decision for me. And so having someone who can advocate for you on that end, if you felt like you were going to get tested, then definitely working with a genetic counselor is the way to go, because it isn't just as black and white as do you have a gene mutation or not. It's really so much more about what you do with that information and how it could affect you and your family members, you know. And one thing that Laura didn't really talk about as much that I mentioned that I'd like to touch on too is that it does, I mentioned this at the beginning of our presentation, is that not only does this come into play with whether it might be your family members or, you know, just your own information or prior, you know, if you have a family history, if you were to get tested, I know most of us here have already been through a breast cancer diagnosis, but it does come into play. So I was diagnosed with a very small stage 1 invasive ductal carcinoma when I had my breast cancer 5 years ago. And for many people, a very small stage 1 IDC, wasn't even a full centimeter. There was no lymph node involvement, no spread or anything. For most people, that might have meant a lumpectomy and radiation, and that could have been the end of it. Not that those aren't significant experiences with it all, but for me, because I had this BRCA1 gene mutation, when I talked with my surgeon about what my treatment options might look like, she gave me that option, but she also said, we consider you to still have about a 50% risk of a primary cancer in the remaining breast if you don't, you know. And I just thought, well, I'm not dealing with that. So knowing that I had this genetic mutation not only informed me about my chances of having breast cancer, it informed me to have to take the steps that I was most comfortable with around my treatment options. So I had a double mastectomy. One side was considered prophylactic. And then even further, they did, because of the type of cancer I had, it was hormone positive, HER2 negative. They did a genomic test on it called the Oncotype test. And that told them that I had a rather aggressive cancer, again, small but mean. And when you couple that with the BRCA1 mutation, they felt it was in my best interest to have chemotherapy as kind of an insurance policy and risk reduction. And so, you know, all of that information really informed what I consider to be my best treatment protocol in this, and not just how high my risk of is if I might have it or not. So there's a lot to consider. You know, for those of you who maybe have other people, even if you did say, I don't know if any of you did have, you know, other than those who've shared, if you did have genetic testing, even if nothing came up, you know, certainly understanding about the difference between genetic and hereditary, right? All cancers are genetic, only a portion are actually hereditary. And the fact that there are still what they consider to be familial cancers, even when they're not known genetic hereditary, you know, hereditary gene mutations. You know, I have people in my life who are now getting to the point of having multiple breast cancers. My mother-in-law had breast cancer, her sister had breast cancer, and now, so their niece is now actually getting tested younger and going for her first mammogram at a much younger age, because even though there hasn't been any genetic or no hereditary component of gene mutation that has come up, there's clearly something in there. There's something going on that puts her at higher risk.
I have another question.
Sure.
She said if you have a parent with a mutation, you should get genetic counseling.
Yeah.
Now, they said I have this MLH1 variant of autism.
Right.
And they specifically told me that my biological daughter did not have to get it. So I'm a little confused.
well,
like,
I would say at that point, if I, again, not being able to answer for Laura fully, but like, if I had to guess, I would say that it's probably because it's a variant of unknown. Like, they don't know what that means. There's not enough information. So, you know, if your child was to go get tested, they're probably gonna end up with the same, you know, if they had that variant of unknown origin, or however it's, you know, whatever they call it, they don't really, your child doesn't really have any more information than you do. So it doesn't really, and without that information, it doesn't really change the, it doesn't really change any considerations around screening, because they don't know what that gene mutation does, right? So for example, in my family, my brother has not been gene tested. Well, we have none of the males in our family have had breast cancer, but it would still probably be really beneficial for my brother to get tested because he has a daughter. And if my brother gets tested and he's negative, then odds are that my niece is probably fine. If my brother turned up with the BRCA1 gene mutation, then when she's old enough, it would make sense for my niece to get tested because she carries that 50% of getting it through my brother, right? So I think that might be the difference, is the fact that there's not, they wouldn't know what to do with that information anyway. So, and it walking, you know, it's, I mean, I don't know how you feel about knowing that you have, you know, how does, if I can ask, how does it feel to know that you have a gene mutation, they don't really understand what it does?
Scary.
Yeah.
Because I have a lot of different cancers in my family, and the one that they said I have, you know, if this turns out to be significant, I think it's an 82% chance of getting colon cancer.
Okay.
And of course, my maternal grandmother died of colon cancer.
Yeah.
Most of everyone else died of breast.
Okay.
She died of colon, so
Right.
I'm negative for BRCA, but again, I have this one that if it turns out to be.
And you have other history of, other breast cancers in your family
Oh,
as well?
yeah.
Yeah. So odds are, I mean, I would say that that would be something that would be worth talking with your, I'm sorry, did you say it was your daughter that you were asking about getting, that wondered about? I would say that's worth talking to your daughter and kind of seeing. I mean, just because the counselor that tested you said that doesn't make sense for her to, I don't know. That might be up to her to decide. Obviously, it sounds like there's probably still reason for her to get seen earlier rather than, you know, I don't know how old she is, but
She just turned 30.
yeah, so she might be in a position to start screening at some point. I will tell you, for anyone who hasn't, we've got a lot of great resources in this area. Great Lakes Cancer Care has genetic counselors as part of their full range of services. And of course, Roswell does as well. I will also tell you that Roswell has a really, really great high-risk breast clinic, breast and ovarian. So if you do have someone, you know, if you have a history or you have a known genetic component and you have someone in your life, man or woman or otherwise, who might be at risk, and you know, whether you know that or not, but have that family history risk, I highly recommend looking into the high-risk clinic, because for me, it was, I mean, I guess I can literally say it was a lifesaver at this point. I would get seen every 6 months, and you know, when I had a clean mammogram in December, and by April I had some stuff going on, and I was mostly in my head, it was mostly anxiety. But when I called them and said, I'm kind of starting to spin out of control, and I think everything's probably fine, but I just can't worry about this another few months until my next whatever. And they said, no, you're high risk. We know this. We take everything seriously. Come in. And they did another mammogram and it's clean. They did an ultrasound and they said, I want to check this one. You know, we think it's fine. Let's do your MRI and rule it out. Give you peace of mind. The MRI showed something, and they did a biopsy, and sure enough, it was there. And so I really credit, you know, them, the high risk clinic at Roswell, taking my high risk very seriously and listening to me when I called and said I had a concern, versus, you know, in some cases, especially whether you have a known genetic component or not, you know, anyone who has a long family history, the more you can take that seriously, the, you know, better I think your odds of catching something early, which right now is still the best case scenario.
I just wanted to mention about genetic and heredity. That was really interesting to me because everybody in my family has it. My mother, all her sisters, they all passed from it. My grandmother, my grandfather, I have it. So I would imagine my girls would get it too. I have 3. And I had the genetic counseling. And I didn't get it from my mom or anybody, and I can't pass it. It stays right with me, which is so interesting to me.
Wow.
I went to Roswell and I talked with them in detail about it. And I said, how did I get this? It was 3rd stage. I would think I got it. I mean, my whole family. And they have ovarian, they have skin cancer, we have cancer, it's running rampant. What they told me is 3 things. They said I got it from number 1, stress. Number 2, they said it was environment. And number 3, it was processed foods.
Wow.
And I lived with all of that.
Yeah.
Very badly. I lived very badly. So the way I look at it, it gave me peace of mind.
Yeah.
My girls went with me to speak about it, and I feel good
Yeah.
that, you know, I can pass it or I didn't get it, but I can actually talk to them about stress and about eating and processed foods, because that is what they said it came from.
And that, you know, and yes, and you know, it's a little surprising. I'm always a little bit, I take everything with a grain of salt whenever even doctors say, well, this is where it came from, especially with something like that. We know that those are common factors. I attribute the timing of mine to extreme stress, you know, long periods of extreme stress. I've had other health situations that have come from long periods of extreme stress before, and so that's what I attribute mine to. But you know, that's great that you have that information. You can understand the difference now too. And it also sounds like part of the process of helping your daughters through this is knowing that, you know, they may not have a hereditary component, but there's those lifestyle components. And with that long family history, it probably is still in their best interest to get screened earlier, and, you know, rather than waiting.
And what I find very interesting is my mother, her sisters, and myself, we were all diagnosed at age 60.
Wow.
That to me is real interesting.
It is very interesting.
It has to be, if it's not from a gene or anything like that, then it's the way we live, the way we've been living, you know, which is very bad.
Yeah.
And so I try to help my daughters, especially with the stress part of it, of things. you
Yeah.
know. I have my one daughter who's kind of stressed over the top, where I think she's gonna have a breakdown at any moment. And I keep trying to tell her, please, I tell everybody, you know, if that is the reason, I mean, I guess I'm trying to believe that is, so much of me can't, it says, I had so much in my family, part of me still thinks like it had to come from somewhere.
Well, and that's what she talked about, the familial, right? Is that it can be, if a family lives in the same area, they kind of live the same lifestyle, they're breathing, they have the same environmental factors, you know, that could be a piece of the puzzle. And we, just like we know about what they call, sometimes called cancer clusters, right? There's communities where for whatever reason, we see maybe a specific type of cancer in one, you know, in a neighborhood or in a county or a town. And, you know, then they're often among people who are unrelated. And in that case, they're often looking for those environmental factors, you know. Would we have known about the water in Flint, Michigan if a whole lot of people hadn't gotten sick? Or, you know, if you've ever seen the movie Erin Brockovich, right? Like those are kind of the things that we look for, that are those keys to, well, why would these unrelated group of people all of a sudden have this commonality with a type of cancer?
I just think more information. I always want to keep learning about it, you know, not for myself, but like I said, for them or anybody else.
Well, I'm a big believer that, you know, knowledge is power. I grew up with that little slogan on like NBC or whatever, Saturday morning cartoons with the little star going across. And it's like, knowledge is power. And I do believe that, you know, I think that the more we know, the more we
Can help
the more we
ourselves.
can. Yeah. All right. Well, it's about 20. We're a little bit over, and it was good discussion. So I thank you all so much. Any final thoughts? If anyone ended up writing down a topic, not a problem if you didn't. I put some paper down, and if you think of a question afterwards that you'd like to get answered, please send it to Debbie or Rob or myself. we'll get it to Laura, we'll get it to somebody else, we'll try and get an answer for you. If you think of a topic for next season, I'm gonna be working on that with our team in July. So getting kind of some initial ideas together. So if you have something that you'd love to hear about in the fall or winter for one of these educational programs, please let us know. Anything,
Yeah, I just,
yeah, Debbie's gonna say just a couple more words and then we're gonna be all done.
okay, so one thing that I want to say, and I think most of you will agree, despite the circumstances tonight of Laura not being able to be here present, I think she did an excellent job and it felt very much like she was here. And I will add to that we're really fortunate, it's just the coincidence, we're sorry for everything you've been through, but you're very knowledgeable and, there might be some questions people had that they didn't think you could answer, but for, those that you were able to. So thank you very much, Amy. I think you did an excellent job. Let's see, Rob, do you have anything?
No.
Okay, Rob has nothing. And does anybody have any other questions, maybe not pertaining to this, but anything about BCN, over the summer, come the fall? Okay, then Amy asked you to fill in those papers if you have anything. And other than that, please watch your email for our monthly newsletter and anything else that comes out, and stop by. As I said earlier, we try to be here, have someone here 5 days a week. Classes will be ongoing, and have a great summer, everybody.
Thank you.
Thank you.